hall is as full as I saw in the morning hours. A rare occasion. People are really so focused here. That's what I can see. And Dr. Khanna is also here. You remember, I won't like to take the name of the city, we were two speakers in the last session and we were not finding the cheering people. Anyway, now endovascular management of hemoptysis. This is, I find, is quite something important in our country because this group of patients, they are not rare. This is something what you can see. This is the physicians they see in their emergency rooms. We see this on our cath table when the patient is shifted there and he is having active hemoptysis on the table and we are doing our job. Or this gentleman, young man who was having hemoptysis, became unconscious, intubated, he is also on the catheter table, and this large clot was brought out with the suction tube. Not a rare occasion in our country. Hemoptysis, if massive, we know 300 to 600 milliliter blood per 24 hours. It carries 50 to 80% mortality with conservative treatment. Asphyxia and exsanguination are major causes of death. Aim of this lecture is how to stop the bleeding by aggressive approach, that is bronchial artery embolization. Let the patient live for the treatment of the root cause, which I am not doing. That is the job of the pulmonologist. The team is a pulmonologist, cardiovascular interventionist, or vascular radiologist. I believe we are already growing vascular radiologists who are doing adequate interventions, but it is definitely the cardiovascular interventions are still at the forefront. Where we take this patient, a hospital equipped with catheterization laboratory. The anatomy, I believe it is very important. Just before we go, I'm thinking about the younger generation. Revise the chapter of bronchial arteries anatomy from textbook of anatomy. It is notorious for anatomical variation. I followed here Ufflecker's classification, which has single right intercostobronchial trunk plus single left artery in 31% cases, right and left separate bronchial arteries, also right and left from the common, sharing a common trunk, and separate bronchial arteries bilaterally, and aberrant arteries. Never forget this, because if we miss it, we may miss many cases and we won't be able to deliver the treatment. It is from internal mammary artery, arch of aorta, subclavian artery, and thoracocervical. How to proceed? We admit the patient under pulmonologist in intensive care unit. Get a quick bronchoscopy done to know which side is bleeding. This is very important, I say. As I said, there's this vast anatomy, otherwise we lose time and inject dye everywhere to find. At least if we know which side of the lung is bleeding, then the job becomes easier. Proceed to the catheterization laboratory and take femoral approach. That's how I do. Keep an anesthetist backup. Patient can aspirate blood anytime. Where to look for is the thoracic aorta level, T3 to T8, 80% between T5 and T6. Air-filled left main bronchus is very good fluoroscopic landmark. I take it very important, and this helps really. Never forget to take a shot of subclavian and mammary arteries before you finish the job. And right lateral or anterolateral for right bronchial artery, and left lateral or anterolateral for the left bronchial artery. This is the usual way how we look for it. And air-filled left main bronchus is the real landmark. and recognized intercostal and spinal branches, avoid embolizing by mistake. Materials required, as it is an interventions meeting, so I'm telling I take as guide wire always Terumo, a coronary guide wire, straight tip Teflon guide wire. These are the catheters are 5 French, sometimes 4 French, sidewinder, cobra, internal mammary, and coaxial catheter. Rarely we use because it is costly. Embolizing coils and PVA particles 200, 300, 500 microns. From right bronchial, preferably sidewinder, allows good delivery of coils. For left bronchial artery, preferably cobra, it hooks well, but deliverability of coil is uncertain. Use of PVA particle is safer. Non-ionic dyes is used only, and use of coaxial catheter restrict to necessity. Yes, in next 9 minutes I try to. This is a normal bronchial artery. Right bronchial artery is hooked, and it is bifurcates upper and lower. This is a typical intercostal artery, tortuous along the lower border of a rib. Don't embolize it. This is the bleeding artery. Young girl, 15 years old, we can see how it is bleeding here. And this is while delivering the coil. And after delivering the coil, thank you. After delivery, we are delivering the coil here, and after that, check whether it is properly inside the vessel. Yes, it doesn't hang in the thoracic aorta. This is something, as I said, the common ostium for both for left and the right. And here the right lower one is bleeding actually. This is the mass, and the dye is going out there. And it was difficult to put a coil there, so it was treated only with PVA particles. Lady, large space-occupying lesion in the right lung, and when she was being operated on the operation table, she started having hemoptysis, so operation was abandoned. I was called to do something to block the bleeding bronchial artery. So I see that I entered the bronchial artery. It is a small one. It must be coming from somewhere else. Yes, it is coming from a bunch of arteries are coming from the right internal mammary artery. And right internal, if I inject here for these small arteries, first we have to inject PVA particles so that they go into this. And so my aim was first to block the lower part of the artery with a coil. So a coil floats in, and then PVA particle is injected so that they cannot flow into the lower part, and then again coil above so that it is now finally sealed. Yes, she is an elderly lady, 66 years. I don't know what is left in her coronary arteries if the surgeon is going to do Rima grafting. Young man waiting for an entry to the army, started hemoptysis. I didn't get anywhere else the bronchial artery. It is the left bronchial artery is coming from the left internal mammary artery. And that had to be coiled, and I hope that by the time this young man of 25 years get an opportunity, needs a bypass surgery, some other better technique has come up by then. It is coming from the arch of the aorta, the same way after intubating the artery, first the PVA particles, and then Then a coil was given later. As this is the coil, how is it being delivered? This can be coils can be delivered with a guide wire softened, or nowadays I also, if I am very sure, nicely intubated intubated the artery, I just push saline and that sets it there. Okay, this is injected. Now, you are looking for everywhere. We are getting the bleeder from the subclavian artery, directly from the subclavian artery. Another branch I have already embolized. Now this is here, first we put PVA particles and then coil if possible. While we are, you see, I still don't know how many feeders are there. When I am pulling it, I find suddenly that there is another feeder. So that had to be, this was basically a cancer of the lung, and he was bleeding profusely, so we had to embolize them. This is the left bronchial artery bleeding, nothing much to show. This basic technique is same here, only I have taken a cobra catheter for hooking. And here, after injecting PVA particles, now going for the data, which is very important. In June 2004, I started with the support of pulmonologists. Without them, nobody will come straight to us. The pulmonologist, physician, is the first person who gets it, and he thinks about it. I finished my 250 cases in June 2012. A vast 8 years I had to work to get my first 250 cases. Age group is very important. They're less than 40 years are 138 cases. That is, majority of them are less than 40 years. Right bronchial artery is the maximum. Left bronchial artery is next. And aberrant arteries, that is from IMA, subclavian, and arch of aorta, were 40 cases, that is 16%. And primary success was 98.4%. Recurrence of bleeding in 30 days was 4%. And recurrence of bleeding in 6 to 12 months, was also 4.4%. In-hospital mortality were 4 patients and really nothing related to this procedure. They had pulmonary infection, septicemia, because never forget that if the patient is coming after some time, then after a few days, and they have already inhaled the blood, and that is the most important nidus for growth of bacteria, and they remain intubated under ventilation for days, can get infection. Where we work and team, it is a Calcutta data, Apollo Gleneagles Hospital, B.M. Birla Hospital, Peerless Hospital, and my own Rabindranath Tagore International Institute of Cardiac Sciences. Adverse result, what we can get? In hospital mortality, we had pulmonary infection following asphyxia. Dislodgement of coil, I had 3 cases. One detected on recurrence of hemoptysis. When patient had recurrence of hemoptysis, the next 48 hours, patient was hospitalized, went to look for it, found that the coil is missing. Yes, it was somewhere in a branch of the profunda femoris artery. And distal embolization and PVA particles causing discrete cerebellar infarct, that happened. Particularly that can happen when it comes from the internal mammary artery, the PVA particles, it can regurge into the vertebral artery, which is just lying opposite it. So while injecting the PVA particles, the dye starts regurgitating, immediately one should stop and not to go further. Complications, spinal cord infarction with transverse myelitis, it is more a potential than a real problem. A few cases of paralysis reported actually after embolizing intercostal arteries. And bronchial infarction after using liquid embolization material has caused, and radiological identification of intercostal and spinal arteries, use of non-ionic dye, and proper delivery of coils and PVA particles can bring complications to zero. Conclusion, embolotherapy to tackle massive hemoptysis is a life-saving, challenging job. It needs more patience than time to learn for an interventionist who is already used to perform procedures on the coronary arteries and other vessels. Scope of work is enormous, and one can really help a large number of people, this being a common problem in our country. And never forget this gentleman, this our Andreas Grünzig. This was our 30 years of PTCA meeting on 17 September 2007 in Zurich. The hall is the same where he presented the first live case 30 years back, now 35 years back. And yeah, I always remember, all of us should always remember him, and because he was one of the pioneers, and on his base only the whole cardiovascular, at least coronary intervention has grown. Thank you very much.
Please. Most of these we are doing with Judkins catheter, and we are using PVA particles on it. But in contrast, we have found that many, around 10-15% of these bleeders are arising from the intercostal arteries also. It's not only bronchial, and around 30% of our patients, they had from the lima or rima and subclavian arteries. And most of our patients, maybe around more than 90%, are tubercular, and the average time after the treatment, after ATT is more than 10 years. They are coming after 10, 15, 20 years because of massive fibrosis, and most of our patients are tubercular.
Yes, that is definitely a matter of experience, sir. I have given you, it is a very meticulously followed up data, what I have presented, because it is not myself only, but we are doing it in a group, and they are followed up very meticulously, and this is just exactly the data what we have got and presented to you. Naturally, when the others may have different data, and for example, with the PVA particle, you have mentioned, yes, I know only PVA particles and stainless steel coils. Say there are from southern India, we have heard about, I have heard about using the other materials for, I have never done it. So what I have done it, I can present it, and I am happy with it. Say glue, I never used it. And about that, you said about Rima or Lima, it is every after you have finished the case, every patient's Rima and Lima should be checked. I mean, if it is from the right side, go for Rima. If it is from the left side, that IMA artery should be checked. So.
Yes, sir. In our setup, we get many cases of...
please bring the...
Hello? Yeah.
Yes.
In our setup, we do get many cases of treated PTB, patient presenting with herald bleeding, not massive hemoptysis, and who have got heavily scarred lung tissue, who might be optimum candidates for definitive surgery in the future, near future, let us say lobectomy or what, or pneumotomy. So what should be the protocol?
I shall tell you I have told you my protocol in a way. What you are saying, that is a later stage development. Yes, I am not treating the root cause. I am just trying to save the life at that time, and then just to stop the bleeding. I said right in the beginning that the actual treatment job is that of the pulmonologist physician or the surgeon, that they have to decide after taking care of the patient. My job is to stop that bleeding in acute stage, so that that life can be saved and they can go for the actual treatment.
Dr. Dhar,
what I have seen, the catheters, you are injecting from the catheters, and there are a lot of reflux with the PVA part.
That's what I mentioned.
Any of them causes, because we are using micro catheters, we are using Miraflex or pro-grade catheters to go super selective and then inject the your PVA particle. So, because a lot of reflux, so it causes diffuse gut ischemia. I don't know, I have seen there a lot of reflux, although it blocked the artery, a lot of reflux.
What you are seeing that after deploying a coil.
No, not coil. I've seen without coil also.
No, they are only angiographic documentations after the procedure.
So you did with the microcatheters?
Yeah. And second thing is that even if after I have injected through the PVA particles through the catheter, I take it out and take a new catheter and go for the checkup angios you have seen. While I mentioned about that also, that while injecting the PVA particles, if there is any regurgitation, we start seeing it, immediately stop, not to give any more further. That means the vessel is now properly filled. Take out the catheter, ask for a fresh catheter, go into it and check it what is your job's result. Not that, I know you mean that there are already particles still in it and that can go for reflux. But you see, every patient I have mentioned about, there are 3 cases where we had cerebellar problem, and that besides that, we never had it anything. And we are very meticulous and careful about it, that not to inject or reuse this catheter ever anymore.
Do you
in
use
any
radial
condition.
route as well?
Not to use.
For the internal mammary artery or branches from the subclavian? Because we have...
It is on that region only. Just opposite that region are the cerebellar vessels, the vertebral vessels particularly. Carotids are unlikely to go. And we had problem with 3 cases, and one has to be very careful about it, and it can come.
What we do CT angio.
We do the CT angio, taken care by the neurologist.
Not in emergency cases. We do the CT angio to find out the anomalous branches.
And where there is any infarct.
The more EG, and you save some radiation to yourself. If elective, I'm saying if elective. If emergency, definitely you have to search everywhere. A lot of radiation. It's a very difficult procedure.
Those who are
really, it's a
but I must tell you one thing, that if you do a bronchoscopy right in the beginning onset and know that which lung is bleeding, then it definitely you can cut short a lot of radiation time, definitely. But if you start going as those vast anatomy, it's possible.
Sometimes, bronchoscopy, pulmonologists say we are not able to find out. Blood is full of blood. So you have to search everywhere.
Right, sir.
So have you ever encountered a patient with moderate to severe hemoptysis with no demonstrable bleeder on angiogram?
Yes, at least 2 to 3 cases I couldn't find the actual bleeder. No question about it. I failed to find the actual bleeder.
So what exactly should be done in such cases?
Perhaps I couldn't intubate the actual bleeder. There must be something bleeding. And in these cases, I do a pulmonary artery angiogram if I have missed a pulmonary AV fistula. That can also give a hemoptysis. But I was not lucky like Panja and not to get somebody. Anyway. Right.